and welcome to the Indian Ocean World podcast. My name is Philip Gooding. In this podcast, I am thrilled to be joined by Dr. Kundai Manamere. Dr. Manamere is a research fellow in the International Studies Group at the University of the Free State in South Africa. She holds a PhD in African Studies from the University of the Free State, as well as an MA in African History and a BA in History from the University of Zimbabwe, where she is now also a lecturer of history. She's published widely in several peer-reviewed journals, including in Third World Quarterly and History Australia, and she's also the book reviews editor of the South African Historical Journal. Finally, she is also president of the Zimbabwe Historical Association. Her research interests include global health, migration, women's histories, and the history of science and technology. In this podcast, we'll be discussing her recently published book entitled Malaria on the Move: Rural Communities and Public Health in Zimbabwe, 1890 to 2015, which was published earlier this year with Ohio University Press. Professor Manamere, thank you so much for joining us on this podcast. Firstly, I want just to ask you about your book and its origins. What brought you to the study of malaria in Zimbabwe, especially in the region that you focus on, which is the southeastern Lowveld region, which borders on South Africa and Mozambique? What are the origins of the project that led to the book, and how did they develop as you researched and wrote it?
Thank you, Philip, for having me. So, what brought me to the study of malaria in Zimbabwe is curiosity. I grew up in the southeast Lowveld of Zimbabwe on a sugar estate called Triangle. So I moved to Triangle Estates in 1994 when I was 9 years old to live with my maternal relatives. When I got there, actually, I encountered a number of anti-malaria activities that were being implemented on the estate. One of these was we would take anti-malaria pills every week on the same day each week at home. This was compulsory. Those who worked for the estate who could not take the pills at home had to take them at work. So there were also, what they called rangers. So rangers, officials, environmental health officials actually, who would move around the estate, homes, etc., spraying indoor residual spraying. They would also drain pools, stagnant pools of water. They would also, apply larvicides in stagnant water. So that childhood experience and memories actually influenced my interest in malaria control. So I've always been keen to know what really informed these activities, and if indeed they were really working. So the book project began actually as a PhD thesis. So as I thought of pursuing a PhD, I considered several topics. But then one day in around 2011, I attended a funeral in rural Chiredzi. That's the rural part of the southeast Lowveld, an area that is closer to the estates where I grew up. So this area is where my mother was born, and I had attended a funeral. Upon talking to people there, an aunt of mine indicated that there were a lot of mosquitoes in the area and a lot of malaria. So I became curious, assuming that the Ministry of Health and Child Welfare had been spraying these areas annually. I asked why do we have so much malaria and so much mosquitoes? And she actually hinted that it seems as if the mosquitoes actually increase in population after they spray. So that actually heightened my curiosity. So I asked if the ministry was not spraying anymore, and she said, no, they spray, but we have realized that it seems the mosquitoes actually, increase after the spraying period. Well, when I asked why, I got quite a number of reasons, but one of the most common reasons was they actually thought that chemical that was being used was no longer working. So it really got me thinking, and I thought, well, I think I'm now convinced that I need to do this for my PhD. So I started reading around malaria control. Then in 2014, I was awarded a PhD scholarship to study at the International Studies Group under Professor Ian Finister at the University of the Free State. And my thesis concentrated on malaria control activities in the colonial period. Then after that, I received a postdoc fellowship whose main objective was to develop the thesis into the book. And that's when then I decided that I was going to take the story up to 2015. Why 2015? Because of the end of the rollback malaria program in Africa. And, the WHO was now taking on, a different objective altogether, which was to eliminate malaria by 2030. As I went through the archival record and the interviews, my particular interest was to know what ordinary people living in malaria areas, they think about malaria, what they think about mosquitoes, what they think about malaria control initiatives. Do they think these interventions methods are working? Is malaria a danger to them? Do they see malaria in the same vein that the government and health officials and international health organizations see? Because what I had realized as I grew up in the law world was that there was little adherence to malaria control measures. So just got me thinking that besides having an official voice talking about malaria, besides the WHO reports, the different reports that are published by government ministries, what are the people on the ground thinking about malaria? So the idea of human mobility actually came about as I realized that my reading of the archival material for the colonial period and my reading of, the archival material and interviews for the post-colonial period almost always pointed to the role of human mobility in spreading the disease within that region and across the borders with Mozambique and South Africa. Yeah, that's how I got to settle for a study on malaria in the Southeast World.
Wonderful. Follow-up question then. So I think some of our audience members, I will find that quite a kind of a provocative conclusion. I think most, certainly the scientific consensus, I think, is to focus on the vector for malaria as the cause of its spread, that being the Anopheles mosquitoes. Mm-hmm. What is it about human mobility that contributes to the transmission of malaria? Could you tell us more about that and how it's an important but also overlooked aspect of malaria's spread, both in Zimbabwe and I suppose elsewhere as well, because this is an incredibly important intervention for thinking about malaria and challenges associated with it globally?
The malaria parasite life cycle involves two hosts, definitely the mosquito as a vector and the human being. So a mosquito feeds on the blood of an infected person, then new parasites are formed within the mosquito. They mature. I'm trying to be as general as possible. They mature within the liver of the mosquito. And then when they are ready to be transferred to the next human, they are transferred through a mosquito bite or a blood meal. So it takes a mosquito and a human to spread the disease. There has to be, that contact between a mosquito, another human being, a mosquito and another human being, and the cycle continues. And How human mobility becomes a key aspect in this discussion is because infected humans, if they move from one place to another, and if they happen to have had been infected by malaria, it's very possible for them to move before the symptoms appear, but they still have malaria in their body. If they happen to move to another place and they get into contact with a malaria vector, there is a possibility of reigniting that cycle again. So malaria then would have been moved by a human agent from one zone into another, as long as within these two zones we have the malaria vectors. The Southeast Lovelord is a very interesting case study for this particular aspect because it is a case study that is located on borders. It is bordering South Africa on one end, it is bordering Mozambique on the other. So in that sense, it allows for movement, cross-border movement of people from Mozambique into Zimbabwe and then into South Africa, or vice versa. We also have quite a number of people who move from Zimbabwe into South Africa. And these movements, the international cross-border movements, have a long historical record. From the colonial period, we had migrant laborers moving from Mozambique, Zimbabwe, and as far as from Malawi and Zambia, going through the Lovelord en route to South Africa. Also had migrants moving from Mozambique into the Southeast Lovelord and into South Africa. And this historical pattern has not ended. It has continued into the present with, the unstable economy in Zimbabwe. People have continued to clandestinely cross borders into South Africa and sometimes into Mozambique too, to find, jobs and also to trade, etc. So we have those kinds of, particular movements which are, cross-border in nature. Then we have movements of people who are coming from rural areas and who are moving into the sugar estates to work. Most of these workers are people who established homes in rural areas that are surrounding the estate. So they actually move from the rural areas into the estates. Sometimes it's seasonal, but sometimes it's on a very short space of time. For example, a person can be at work from Monday to Friday, and then the weekend is spent in the rural home. So we have those kinds of movements too. We have movements that are inspired by seasons. When the sugar industry is cutting cane or planting cane, it hires temporary labor for those tasks. So we see people coming in every 6 months and going back to their rural homes. So we see quite a lot of internal movements which are cyclical, as well as cross-border movements which are cyclical. And it is that circulation between especially the estate areas where malaria has been significantly and successfully controlled, and rural areas where it remains a very big challenge that become interesting. It is also interesting in a sense that we also have, South Africa claims to have done a much better job in controlling malaria as compared to Zim. So they also feel that, as people move into South Africa, they are bringing in malaria. They are parasitized and they have the ability to move the disease into a zone where malaria has been significantly controlled. Border areas are tricky in terms of disease control. I think even as shown by the recent COVID-19 pandemic. border areas are quite tricky because most of the movements that we are talking about are actually clandestine. People don't cross borders in these areas using official border points. Not that even at official border points, malaria is tested. It's not tested. So it doesn't really make much of a big difference. But if it were, still, we're going to have significant challenges because the majority of people that cross into South Africa or from Zimbabwe or from Mozambique into Zimbabwe actually use clandestine routes, which are not manned by any official, or any border or health official. So they are able to move with the disease in their bloodstream and cross borders. So this has always been a difficult phenomena right from the colonial period. It was quite difficult to control malaria because of clandestine cross-border movements. You would realize that a reading of WHO archival material shows that by the mid-1950s, labor migration had become quite a challenge for the Southern African countries because of the fact that the malaria epidemiology was different in all these countries. And in most cases, because of colonial policies, it was mainly urban areas where malaria had been controlled. Colonial labor that contributed to labor migration was mainly coming from rural areas where malaria was prone. So you would see a constant reinfection of, a constant import of malaria from rural areas into mining areas as people would go into urban areas and work. And the moment they go back home, they get reinfected. They bring back malaria again. They bring it back into urban areas and into other countries. So the cycle keeps going. And then there's this phenomenon of home that I think significantly contributes to malaria circulation. In the Southeast Global world and in Zimbabwe in general, we believe in rural homes. So no matter how much time you spend in urban areas, we have permanent rural homes. Places where we have to go for holidays, for funerals, for family gatherings, etc., for Christmas celebrations. And it is these movements, these circulations that come with, the concept of home and work that also increase the possibility of spreading the disease to an extent that we now have, a serious challenge with what they call imported malaria, threatening urban areas in Zimbabwe.
Thanks very much. Now, I want to kind of to get into some of the more granular history of these rural areas and and you alluded to like kind of a rural urban divide there where malaria is much more widespread in rural areas than in urban areas in the present. Now, historians of colonial Zimbabwe and colonialism in Africa, more generally, and even historians of white settler colonies elsewhere as well, will probably be very unsurprised to learn from your book that colonial efforts to control malaria focused on white-dominated areas. Firstly, urban areas, and then from around the 1920s, mines and white-owned farms. Black majority areas, especially rural areas, were neglected. And indeed, in the 1950s, as you mentioned in your book, Africans were forcibly relocated in the southeastern low veld region into areas where sleeping sickness and malaria were rife. I suppose you kind of drawn us to a picture of a situation in the present and the more recent past as well, where this rural urban divide still seems to be quite present. I suppose what are the legacies of like these racial and regional policies by the colonial government in the late 19th and early 20th century? Are the kind of current rural-urban divides kind of a symptom of that? And can you see kind of a long-term trajectory here with its roots in colonialism that is still present today?
Yes. One of the key consequences of racial policies, colonial racial policies that guided malaria control was the spatial distribution of the disease. And as you rightly pointed out, by the 1920s, malaria primarily becomes a rural disease with less occurrences in urban areas. And unfortunately, it has remained as such. It's still a very much rural disease. And in fact, health officials in Zimbabwe still insist that we do not have malaria in urban areas whatsoever. Despite, of course, rumors and suspicion that we now have new cases that are being discovered in urban areas. Health officials still insist that this remains a very rural disease. And I think that's the first legacy that we can point to. Malaria still remains a very rural disease. In addition to that, I think it's the fact that these African populations that were forcibly moved into malaria-prone areas were not relocated upon independence. They continued to stay in these unhealthy zones. And as I show in the book, they regard these unhealthy zones as their homes. So it means the cycle then continues, because no matter where you go, you still find yourself back in the unhealthy zones. And the homework arrangement, which we talked about earlier, becomes another visible legacy of the colonial racial policies, because the colonial period did not allow Africans to have permanent homes in urban areas. If we take the case of the southeastern low-veld sugar estates, you realize that up until the late 1980s, the housing within the estates did not accommodate families. It was housing that was meant to accommodate contract labor. And you find that in most cases, families would have to be left in the rural areas, and the worker had to move in between to satisfy his responsibilities as a father, a husband, and a worker. So because of that colonial arrangement, you find out that most Africans ended up not even building homes in urban areas, even when the opportunity was later availed by the post-colonial government. Most people still have that thinking that a very stable home is a home that you build in the rural areas. It's actually cheaper to manage too, because you don't have any bills to worry about. So that's another legacy that I think a racially based legacy that is also influenced the spread of the disease, because it has have maintained that divide, the rural urban homework divide. We eventually continue to pose a risk of importing malaria back into urban areas as we move between these zones.
So challenges malaria are clearly historical, ingrained, and multifaceted. One of the kind of major themes of your book is, like, of course, successive colonial, white minority, and post-colonial governments have made several kind of top-down attempts to arrest malaria, to control malaria in Zimbabwe, including in the southeastern Lowveld region. But as you kind of alluded to, actually, when you're discussing the origins of the project, about how the people who you met suggesting that their approaches with the spraying of insecticides didn't work. That there's been, despite attempts to, like, kind of official attempts to institute malaria controls, individuals and institutions have often refused to follow these official regulations, guidelines, or recommendations. And of course, and again, you alluded to the COVID-19 pandemic. Listeners will be well aware that several government-driven attempts were all over the world were resisted by large swathes of the population, whether those be vaccination programs or isolation mandates. So I suppose the question I want to ask from this, what drives or what has driven the limitations of top-down approaches to malaria control in Zimbabwe, especially in the southeastern Lowveld region. And I suppose, do you have an alternative, or what do you propose as an alternative, or the starting point for an alternative?
Okay, the Lowveld malaria control programs are largely part of the national control programs. So generally, I think what drives the top-down approach in malaria initiatives in Zimbabwe is that the country continues to largely depend on external funding from international organizations for malaria control. As such, I think he who controls the pest determines the priority and the methods to be used. In that way, then the government kind of gives the agenda to international organizations. And this is not a new thing. I think following the formation of the WHO, you find that the agenda for global health was then transferred to this international organization, and it seems as if governments, or African governments rather, are kind of leave it all to international organizations because they are avoiding costs. And at the end of the day, it is international organizations that set the agenda for them, and they are there to receive and apply. The alternative for me would be a situation where the government also seriously invests in disease interventions and complement existing global efforts by researching into local determinants of malaria and tailor-making solutions that address local challenges such as human mobility. I think Triangle Estates presents a very good example, a unique example within Zimbabwe that can inspire and influence national control programs. This is the only, as far as I know, this is the only place where malaria has been significantly controlled to the point of near elimination. And if we look at the history of the Triangle Malaria Control Policy, you realize that they do not necessarily rely on a single method of controlling malaria. Theirs is a multi-pronged approach that also includes larviciding. It also includes house screening of windows and doors. It also includes methods as old as draining stagnant pools of water. Then we have IRS. Then we have mosquito nets distribution. So for me, it's a practical approach because it seeks to arrest malaria at every turning point in the life cycle. Some of these methods try to arrest malaria at reproduction stage. Some, target adult mosquitoes as vectors. Some target parasites within the human bloodstream. And this is how collectively these methods actually managed to reduce malaria in the Lowveld to an extent that by 1979, the Ministry of Health actually regarded Triangle Estates as a healthy island in a sea of hyper-endemic malaria, meaning the sea is the surrounding rural areas where the government was controlling the disease. And because the government was controlling the disease, relying more on IRS than any other method, you find that malaria prevalence continued to increase as compared to the estates. So for me, if the government could invest more into other methods besides those that are recommended by WHO, so that these methods become multi-pronged and complementary, I think it would actually help. And in this case, I think it is very possible for the Ministry of Health to study movements, to study these circulation movements. They are not difficult to see. And they could actually, find a way of employing chemoprophylaxis in an ethical manner to control the parasite that is moved by human beings or human mobility. I think for me, the alternative is we should not rely on one or two methods. The alternative is let's go multi-pronged. Let's take into consideration all those earlier methods that that were used before and successfully so in other areas, so that we arrest this, and we also independently contribute to malaria initiatives locally within our countries. And we also get the opportunity to set our own agenda in which areas are of priority and which methods are we going to employ because of the local context prevailing in that area.
So one of the things that really comes across in your book is that from around the 1950s, this is when IRS, so that's indoor residual spraying, becomes really pervasive as the dominant method by which central governments, successive governments, attempted to arrest malaria. Now, this marks kind of a major kind of shift. Like I kind of reading your book, I was really struck by how up to that point, up to the 1950s, kind of the medical literature being produced in Zimbabwe, including by the colonial government, often tried to, or at least don't know whether it tried to incorporate, but certainly recorded local methods by Shona populations about how they combated malaria within their communities. And then these kind of get, in terms of the government's attempts, this kind of literature of looking at local methods kind of combining that, I should say, with methods that they had kind of learn or try, or lessons they tried to learn from other places in Africa, Western Africa, and also from institutions in Europe as well. So kind of in the historiography, this might be referred to as some kind of hybrid knowledge that they're contributing to. But this seems to completely be erased by the beginning of IRS, by the use of insecticides and pesticides like DDT as well. Now, clearly, the central government in the 1950s, and then it seems like in the present as well, like all these kind of local practices, they've forgotten them. Are they remembered at all by people in the region? There's a large drive in kind of in the context of climate change for accessing and identifying kind of big air quotes indigenous knowledge to combat climate change. So that kind of this local approaches are locally grounded. Do people in the region kind of remember older methods that predate the use of IRS and DDT for combating malaria? And do they advocate for their usage now in terms of having these kind of local initiatives, contributing to these multi-pronged approaches to malaria? Is there anything there at all? Or is this something that maybe we need to push beyond as some kind of unattainable ideal?
When I started to work on malaria, one of the key aspects that I thought would be dominant in my work was African experiences of the disease. Part of my research also tended to focus on, African understandings of malaria. I also wanted to know what kind of methods were used prior to colonialism, prior to biomedicine, to control the disease, and what kind of methods people were still using in during the period of my study, which is from right about 2014 to 2018, when I carried out fieldwork for this book. So I also questioned people on, what are the methods they employed in rural areas, besides, the government initiated spraying programs and the use of mosquito nets. And I found out that their answers kind of resonate well with what I had also gotten in the archival. So in the archival record, where the first medical director, Andrew Fleming, indicated that the Shona people actually had their own way of dealing with mosquito vectors earlier on, even before the discovery of, the germ theory. So he said that mostly Shona people would build their cattle crows closer to their homesteads, mainly because they understood that mosquitoes were more attracted to cattle as compared to humans. So if a crow was built near the homestead, it actually meant that it would attract mosquitoes far away from the people. Then the Shona people also used plants. There are certain plants like a plant that was very common during COVID in Zimbabwe, which is locally known as zumbani. It's used for various uses, but in regards to malaria control, it is people burn it in their homes at bedtime because it produces a very awful odor that and the smoke that it also produces kind of disturbs mosquitoes and they go away. You can also rub the leaves of that plant and spread on your skin so that it becomes a repellent of some sort. The other method is to burn cow dung in the sleeping rooms. You can burn cow dung. It also produces a smoke that kind of repels mosquitoes. I also got information about these very methods when I did my fieldwork in between 2014 and 2018. People told me that they burn cow dung, they burn zumbani, and they also believe that the existence of cattle and goats within the homestead also helps them. But I haven't come across yet any advocacy with regards to adopting indigenous knowledge systems in malaria control, either from academics or from health officials in Zim. It seems as if even those people that employ traditional methods in rural areas, it is because they cannot afford the biomedical, interventions. You may find out that I think currently people are supposed to buy their own mosquito nets, and sometimes spraying is not done because of government problems or inability of government to come and spray. So people then resort to traditional methods of getting rid of mosquitoes because the prohibitive costs that are related to the pesticides, etc. But I think as a country, as a ministry, we haven't really started talking about adopting traditional methods of controlling malaria into mainstream malaria interventions.
Okay, thanks. That's so interesting. I'm going to ask one more question about your book. Obviously, your book stops in 2015, and you pointed that around 2015 was a period when malaria transmission was worsening in the southeastern Lowveld region, but also more broadly in Zimbabwe. I suppose, what's the situation now? Has the situation changed better or for worse in the last 10 years? And if so, how?
It's a sad situation. The malaria
Okay.
situation has worsened. It continues to surge. From 2015, 2018 was a very bad year for us. 2020 was characterized with serious epidemic malaria across the country during the COVID-19 pandemic. Then recently, WHO reported that Zimbabwe had recorded 111,000 cases of malaria and 317 deaths during the 2025 malaria season. Malaria in Zim is seasonal. The season runs from November to June, the wet months. the country. Those were the reports for the cases for the 2025 season. But this was up from 29,000 cases and 51 deaths in 2024. So that's quite a huge surge, especially this year. For me, there is no light with regards to the elimination goal. It seems we are going backwards. But I think it's mainly because of course, climate change. We have had, it seems like seasons are changing, and we have had seasons of droughts and, seasons followed by seasons of heavy rains that actually, create a good breeding grounds for the mosquitoes. Then there is also the disruption of the healthcare system because of the COVID-19 pandemic. I believe, especially in Zimbabwe, the concentration on COVID-19 during 2020 to 2021 actually impacted negatively on malaria control. I feel that so much resources were channeled towards COVID, leaving malaria-prone areas vulnerable. And that legacy has continued. We had the consequences of those decisions actually affecting malaria epidemiology in the present. Then the fact that the government or international organizations have also stopped distributing nets or free nets to individuals in rural areas who are mainly, living under the poverty datum line also affects this also contributes to this surge. And lastly, we have not received malaria vaccines yet in Southern Africa, despite them coming out a few months ago. We are still to receive the malaria vaccine. So that also kinds of put us at a very vulnerable position, to the extent that I think, given that we're a few years away from 2030, the elimination goal is under threat. Sometime last year, I attended a meeting between ministers of health, and I was sad to hear that one of the key issues on the agenda was the fact that the manufacturer of DDT in India was going to stop production sometime this year, I think, or sometime next year. So they had indicated to SADC countries who the major beneficiaries or the major users of DDT in malaria use, that they were going to stop production because it was not profitable for them to continue producing it anymore. And, there was a lot of discussion on what's next, because the region greatly relies on DDT in malaria control. And if it's going to be stopped, it also means because our governments are not ready to invest into synthetic pesticides, it is actually it may actually increase malaria prevalence in the next few years.
I'm really sorry to hear it. I'm sorry to have made the final question about your book to be a reflection on such a sad state of affairs. And as I said, I'm really sorry to hear it. In some ways, I suppose it goes to show how important your book is, which just historicizes all these processes that are leading to it. And I really want to thank you for discussing it with me and for our audience. It is really, and it is a really wonderful book, not just because of its importance, but for the way it's written as well. It's a fantastic read, and I was thrilled to get my hands on a hard copy to be able to learn from it. But before I let you go, I always finish these podcasts with a final question, and that is, what are you working on now?
Currently, I am working on two projects. The other one is on its initial stages. It's on malaria control in the region, in the SADC region. I felt that after I have told the Zimbabwean story, I would really love to research into a broader regional history, which will also include cross-border efforts in trying to control the disease. So, but this is still in, its initial stages. I'm still trying to collect data within Zim, that which is available within Zim and within WHO online archives. Then the other one is on the historical epidemiology of HIV and AIDS. This one is inspired by the fact that, there has been resurgence, if I may use the word, of HIV new infections in the region. And at a time when I think the public health community thought that with the ARV, they'd done very well in controlling the disease. And so I found this to be an interesting turning point, a point that inspires us to look back, to check what has gone wrong or what went wrong and what is bringing back this disease. Anything to do with previous interventions? Is it anything to do with, other contemporary problems that, we might be facing in the region? So that's the other project that I'm currently working on.
Again, two very important projects. I really look forward to reading more about them in the future. Thank you so much for discussing them with me, also discussing your book, for writing your book as well. It's been a real pleasure to hear you talk about it as well. Before we go, I also want to thank Sofia O'Reilly, who will be editing and producing this podcast. I also want to thank you, the listener, for listening, downloading, streaming, however you access your podcasts. I want to finish by reminding you that this is the Indian Ocean World Podcast.
We would like to acknowledge the generous support of the Social Sciences and Humanities Research Council of Canada. The Indian Ocean World Podcast is produced under the SSHRC-funded Partnership, Appraising Risk, past and present. The podcast runs in conjunction with the annual speaker series at the Indian Ocean World Centre at McGill University, Montreal.